So what else makes psychiatry this quirky medical field? So in all medicine, the first line of treatment, whatever was proven to work best is tried first. So, picture this. A dear one finds that he or she has cancer. You go with her or him to the oncologist, and the doctor says this: we have a treatment that works for 90% of patients, but we reserve that for last. First, we try stuff that only works for 30% of patients. Now, you would at least be very outraged by something like that, because it makes no logical sense. It doesn't survive. There's no possible reason for that, except for side effects. And that's what psychiatry does. For example, ECT brings depression to full remission in about 80 to 90% of the cases. The cognitive side effects, by all measurable variables and by all, I want to say, relevant, serious research, shows that the cognitive impairment associated with it recovers within 6 months. If you do maintenance ECT for someone with severe recurrent depression, let's say a session every month or 2 weeks or 3 weeks, right? Just to keep it going. Not only works, also allows the patient to recover his impairment in short-term recall. That is one of the things that scared the most, aside of everything we saw on TV, right? Painting ECT as this sort of the satanical thing. But we don't use ECT as a first choice. But a lot of people that research and practice ECT continues to ask the question, why don't we do this first? The basic answer that comes from guidelines is that there's a reason to keep these specific guys last. And the reason is really the side effect or sort of a risk-benefit balance. Clozapine has significantly better results in terms of positive symptoms, has less dropout rates. So, and one of the reasons people say, if the patient doesn't have good compliance, don't prescribe clozapine. However, clozapine is the medication with the best compliance rates, independent of patient selection, cost effectiveness, life expectancy, functionality. Now think about it. This medication is so toxic. Patients on clozaril live longer than schizophrenic patients on other antipsychotics. It's the last choice, right? Now, it should be tried after 2 failed attempts with proper compliance of second-generation antipsychotics. Now, most doctors don't do that, right? They keep, no, let's try this, let's try that. And they keep this, and that's my problem with neuropharmacology, because it claims that, this one acts different, that one acts different. We have no freaking clue how these medications work in the brain, why they translate into improvements, why an antidepressant, but serotonin, I don't know what. Okay, how does that translate into improvement in mood? We don't know how the brain works enough. We don't have enough knowledge of all the relationships. Why giving anticholinergic medication improves tremors if you didn't change the dose of dopamine blocker for patients with Parkinsonism induced by like EPS, right? Induced by antipsychotics. We don't know, right? There's some balance in between those guys. Oh yeah, we know. So what I'm trying to say is we have evidence-based medicine. We have evidence-based psychiatry to try those things, right? But we frequently don't do. So lithium is the mood stabilizer with best results to reduce frequency of manic episodes, right? Lithium itself has an indication saying, one of the criteria is if compliance is believed, right? If you think this patient is going to be compliant. And the reason for that is because poor compliance to lithium is worse, or maybe worse than no treatment at all.